Good afternoon, all. My name is Bushan Sabnis, and it's a tall task to follow Karthik, my fellow uni enthusiast. I'm completely a fixed bearing guy, so my views are entirely different from Karthik. So don't get confused about anything. So let's talk about fixed bearing unis and how they are different from TKR, especially in the Indian scenario. So that's my favorite slide. So what disclosure? I still drive a car like that when a lot of you are driving Bentleys and Rolls Royces. So that's me. So we'll talk a bit about joint replacement. So Professor Lobenhofer is a very big enthusiast of joint preservation from Europe, and his famous statement is joint replacement is internal amputation of the knee joint. Very harsh, I agree, but if you think about it, it's sensible. Now, if you remember your education, your post-graduation, a below knee amputee does much better than an above knee amputee. So the amount of tissue saved is far better for recovery and rehabilitation of a patient. So let's look at this as a limited amputation as compared to a complete amputation. Now, you can easily do a simple partial knee replacement or a total knee replacement such as this with excellent results. But the argument here is, why not just do a TKR for every patient with medial compartment arthritis? Because unis are known to have slightly higher revision rate. We'll come to that in discussions later. Why is it so? There's a very famous paper from David Murray's group from Oxford, which shows that it's just because it's easier to revise uni to a total that people are doing total knee replacement as revisions for unis rather than managing a problem such as the patelectomy or patellar osteophytectomy that would have solved the problem in a few of these patients as well. So in any patient, forget about young patient, I feel uni will give you a better physiological function, faster recovery. Of course, there's going to be less bone loss and less blood loss, less risk of complications, and ease of future surgery. So don't make things complicated. Let's have a simple coffee pot, rather not try and do a chemical formula for it. I will quote a few papers here and there, but what we rely mostly on are systematic reviews and meta-analysis. And it has been shown that uni will give you better function based on various RCTs and various trials in early and mid-term follow-up. Now, the differences in revision are mainly in the older papers, and newer papers do not show much of a difference in our revision rate of a uni as compared to total knee replacement. Indian patients are of a different breed altogether. We have people who are slightly higher in terms of BMI with weaker bones and short stature, and generally they require a size 1 or 2 implants, mainly in females, and maybe size 3, sometimes 4 implants in males. They always expect to sit cross-legged for some reason, even though they are not accustomed to doing so, and all of them want to start yoga, running, treadmill post-surgery. So they haven't done that in life, but they always want to know whether they can do running after surgery when they don't need to. When most of them wear fancy Nike running shoes, but they haven't run even 100 meters. So you need to be very careful about how you approach to your patients. We are special people, so we need to be careful about how we do our surgeries. Even the olden types of unis which are not designed to bend beyond certain degrees, people did everything with them, but things are changing in terms of a population as well. The size of the TV has reduced, but the size of the tummy has increased. So all of us are becoming slightly overweight. When I say all of you, I don't include all of you. It's more on this side. So patients are becoming slightly overweight. Their expectations are weird. My experience was mainly doing Oxfords before. About 12 years back, I stopped doing Oxford and shifted to fixed bearing unis. And this is sort of the things that I talk about. Now, you heard Karthik's talk. There's a lot of discussion about AMOA. I'm slightly different from that. AMO is purely for Oxford mobile bearing uni. I feel a grade 4 medial compartment arthritis is the indication for a unicompartmental knee replacement. Forget about the patellofemoral joint. As long as there is no lateral joint discomfort, you should not worry about the lateral compartment as well. Because you're going to keep the uni in varus, that means the loading is going to happen on the medial compartment, on the artificial joint. So they are going to get next 10-15 years of normal function. You need to do your normal set of investigations as was discussed before, so I won't repeat the same things. Always make sure your x-rays that you look at are standing and not supine. You can always do valgus or varus stress tests. I don't do them in my practice. Again, a variation from Karthik. I normally get MRI for most of my patients, and I think scanogram is also a good indicator to see the severity of varus. So if someone has the Mikulicz point lying below zero, around -10, -20, then that's a indicator that there's a pretty severe varus, and you need to correct that by different ways. And it also shows, scanogram can also show things which you don't see on a normal x-ray. So always get a scanogram. I think MRI is must in my practice. Again, slight variation. I want to make sure there is grade 4 arthritis in the medial compartment. I want to make sure there is no lateral meniscus tear, or there is no lateral femoral condyle weight bearing area condyle damage. I have been surprised before. Maybe I'm not astute in looking at the x-rays as Karthik, but I have I'm trying to make my practice as mistake free or as error free as possible. So much so that if I'm worried, I would put a scope in before the surgery to confirm that I'm dealing with a medial compartment OA and the lateral compartment is fully intact before I start the surgery. Of course, don't forget the hip and the spine, because a lot of times you're fooled into believing a mild or moderate MCOA is severely painful because of your hip pain which is radiating down. And I've even gone to the level of getting a bone scan done in patients in whom I was not sure if the pain was purely coming from the medial compartment arthritis. So this is a typical patient that you would see with a medial compartment OA. There is slightly hazy ACL with maybe some ganglionic look or mucoid degenerative look to the ACL. There is a small lateral osteophyte, but the lateral meniscus is intact and there is a good lateral cartilage, and they do really well with a fixed bearing uni such as this. Again, another patient, similar, the patellofemoral joint is slightly iffy, there's a bigger lateral osteophyte, as you can see. And again, same works really well. What about patients who are overweight, but they're completely having severe pain? I think such patients, you need to make sure that they get a good scanogram done. Now, those of you with keen eyes will note that there is no grade 4 OA in this patient. This patient has severe painful varus condition. And if you look at the scanogram, the Mikulicz point is lying far to the inner side. So these patients are obviously, in my book, not ready for uni or total yet because they are not that bad yet. So I would do a double level osteotomy such as this. So I think we should be able to do whatever is required based on the severity of the arthritis and the patient's stature, rather than just doing one surgery. Another example. So the factors that Karthik already mentioned, I'll just quickly go through that. I won't repeat everything again and again. So the factors that have been taught to be pro or against a uni versus TKR are age, sex, socioeconomic status, BMI, status of the PFJ, status of the ACL, and the expectations of the patient. I think the last one is the most important. Let's skip that. So whether it's too young or too old, so 84-year-old having bilateral unis done or 51-year-old bilateral unis done, both do really well if you select your patients well. I think sex is a moot feature. A good, well-performed surgery, a good-looking uni will always do well in selected patients who are selected properly. So I think age and sex we should not worry about. That's a housewife, that's a mother of a physio who's a farmer and still working after a partial knee replacement. I think 5-6 years down the line. That's a 92-year-old ex-CEO of a multinational company, and that's a driver. Both of them had the same surgery. Both are doing really well. I did her surgery when she was 86, so it's 6 years down the line, and she's still doing well. Big legs such as this can also be done. Patients who have weak bones or weak muscles can also be done like that. PFJ, I think pre-existing PFJ is touted to be a very severe problem for doing a uni. I've done unis for PFJs looking like that, and they still do really well. I think it's important to select your patients and make sure the pain is not coming from the PFJ but coming from the medial compartment. Is the most important thing is expectation. I did this gentleman's surgery I think 4 years back, and he came to me saying, I'm not happy with my knees. And when I asked, he said, I'm not able to run as fast as I could before. So it's all to do with your expectations. If you get good looking exercises, but you haven't discussed with the patient that he or she can do things or cannot do things, then it's going to be quite difficult. Uni after HTO, that's a fairly standard thing nowadays. So if you are got a patient who has had a badly done HTO which is failed because of progression of medial compartment arthritis, uni works brilliantly. I've done a good number of cases till now. This is done really well. Uni with ACL. So this gentleman had a chronic ACL laxity with really grotty medial compartment. This is 4 years down the line. That's his X-ray done really well. This lady is, I think, 1 year down the line, and this is the video, I think 4 weeks from the surgery or 5 weeks from the surgery. You can see the X-ray. It's all inside ACL that I had to do because the tibial size was too small, and I had to do a smaller socket on the tibial side. Works really well. A common question asked about longevity of the implant is the biomechanics of the knee after surgery. We all know that uni is a true resurfacing, and it behaves well because of the native ligaments and native supports of the knee joint. We are not correcting significantly. So the behavior of a uni is almost similar to a natural knee when you see a kinematic when you see the biomechanics and the kinematics on various models such as this. A funny thing about uni is that it makes all the difference to the patient and the surgeon unless you get a good X-ray. A lot of times patients are sent with X-ray such as this and are told that the uni is not been put properly, or something like this, in saying the implant is not placed properly. It's all to do with psychological behavior of some of the doctors and some of the patients. So you need to get a good looking X-ray for your patients. X-ray assessment is equally important, and if you get an X-ray such as the first one, everybody is happy because you can see a nice spacer. You can see the alignment of the implant really well. Oxford Group has come out with a very complicated framework about assessing various angles around the knee, and I think it will take a lot of time to do this routinely. But in simple words, if you get a good looking, well aligned uni, they do really well. What about bicompartmental? For someone with a really bad patellofemoral arthritis and really bad partial medial compartment arthritis, yes, you can do bicompartmental if you are that brave. I have done a few, but I ultimately felt it was better to go for a total knee rather than a bicompartmental knee replacement. I think the morbidity is almost similar to that. Lateral unis, for some reason, lateral unicompartmental knee replacement patients are some of the happiest patients that you'll ever operate on. Their valgus gets corrected, they are very comfortable, and lateral joint itself is more forgiving, so the pain is not that bad. I think I've shown this video before. I did her total knee replacement 2 years back, and I did her uni about 10 days back on the other side, and she did not want me to do a total knee. That's possibly failure on my part, that I didn't do a proper job with the total knee. But for uni, she's really well. The gentleman on the left hand side is a dentist. I think he retired just now. He's practicing in US, and he came for a bilateral partial knee replacement. This is his video about 5 days from the surgery. You can see the dressing is still on, and he's just trying to show off, in my opinion. So he showed how he started walking on the first day, how he was feeling better the second day, and how he was able to throw the walker the third day, and he's able to walk normally. So I think if you get patients like that, you are going to be very happy in terms of your practice. I'm not saying total knee doesn't give result like that, and I have indeed a good subgroup of patients who are doing really well. But if you are able to get the same result with a partial knee replacement in about 50 to 60% of the patients who walk in the OPD for you, I think it's a good idea to do a partial knee as and when possible. I'll just show a couple of papers. I don't want to bore you to death with all the papers. So uni has better function in terms of range of motion, in terms of recovery, in terms of going back to work, and all the all the knee scores that you can think of. I'm slightly biased towards fixed bearing knees, because I feel ultimately a fixed bearing knee is more forgiving as compared to an Oxford knee, and that's going to work in your favor, especially if when you're not doing robotic surgery. Age-wise, this is the central paper is for patients over the age of 80, and there's another paper I'll just show for the patients under the age of 50. 55, all of them are showing excellent results with a partial knee replacement as such. So I think unis are tougher than total knee replacements and are not forgiving at all. But if done properly in properly selected patients, they can make your subgroup of patients some of the happiest in your OPD, and this possibly is a truly forgotten knee. And I think when your patient comes to you about 3 or 4 years down the line and shows that this is my function, you're generally very happy. So I think it's important to do a good partial knee replacement as and when possible. And I think about 50 to 60% of patients who come to you for a total knee can be managed with a partial knee replacement. Thank you.